Okay, so we're back with this week's case study on that person who was just kind of altered, short of breath, and so on. So you're dispatched to that diabetic problem. Dispatch advises you your patient's a 54-year-old male with high blood sugar. You arrive to find your patient lying on the couch. He only responds to pain and is breathing rapidly and is gasping. His skin is hot, dry, has no palpable pulse on the radial pulse, but has a rapid, strong carotid pulse. All of his mucous membranes, so his lips, his eyes, everywhere is just very, very, very dry. Give him a GCS of a 214, a slightly patent airway, no crazy adventitious sounds that we're hearing coming out. Deep and rapid breathing though. Skin warm, hot, very, very, very dry. For disabilities, none other than just being altered, negative on a Cincinnati stroke scale, no neurological deficits to one side or the other, no neurological things suspected. In the environment, we looked at it to be clean, well kept, nothing crazy going around like to be suspicious of overdoses and whatnot. So in our assessment, we found a heart rate of 116 sinus tach, was 97%, and that was on just room air. But here's where stuff started to get really just crazy, really, really stuck out to us, was that respiratory rate of 36 with an end tidal of 20 and hypotensive, 74/56. So additionally, we found a oral temp of 102.1 Fahrenheit or 38.9 Celsius. And that glucometer just gave us a reading of high. Not as in hello, that it's like warming up telling us, but it's high. It's beyond reasonable recognition readings, which depending on the device you have, we know is around over 500, ideally most of them. So in that, some secondary assessment stuff we're finding here is the patient had Polydipsia. So that is just very, very thirsty, just frequent thirst, just seem like they can't get enough to drink. Lung sounds clear and equal, heart tones good, lub-dub, nothing crazy there. Abdomen soft, pliable, it was symmetric, non-tender, nothing crazy sticking out there. And then urinary polyuria, just frequent urination. So polydipsia, polyuria. Additionally, in that secondary assessment, we found out the patient was a type 1 insulin-dependent diabetic, also kind of with that trifecta of hypertension, hyperlipidemia, high cholesterol. They recently had a knee replacement surgery 10 days prior. The wife and bystanders was telling me that the patient's compliant with all their medications, that there's no suspicious stuff going on there, that, you know, right on the money, wife makes sure that the husband takes all of his stuff as he's supposed to. The wife also describes that polydipsia, the polyuria, as well as limited mobility since that surgery. So it kind of gets us starting to think of multiple things that this could be. So a lot of these are, stuff is being put into the comments and whatnot. So we're starting to think, well, it's maybe something with the insulin. Well, blood sugar was high. So it's almost like that they're not getting enough insulin. Okay, so we start thinking about this, kind of coming back to this. And then other things coming in here. We talk about, infections, that fever being present, that, anytime that there's a fever, that's immediately we're going to is infection. Or maybe the infection got so bad that it's caused the sepsis. And then we start thinking about, well, is it DKA? Is it overall shock? Well, yeah, it's really kind of involved in all of those things. Okay, so what this situation plays out as is dealing with that diabetic who has an infection that's spread and become septic shock. Okay, so a lot of that kind of revolves around one big culprit. That's cortisol. All right, so the diabetic patient, compliant with all the medications, taking the insulin as they should. Awesome. So it should be regulating their blood glucose within their normal parameters. But what could be happening here? So we've got that surgery, we've got that fever, so we know that there's an infection. Okay, so definite. Yep, infection, 100% going in there. Well, now that infection gets so bad that it starts to develop sepsis. Well, sepsis, that form of shock, is putting significant stressors on the body. So when all those stressors are being put on, that increases all the cortisol levels. Okay, well, cortisol, it just does not like insulin. So when cortisol is in elevated levels in our body, it makes the body very insulin resistant. Okay, so you can see the same thing in a type 2 diabetic, to where if they're taking, an oral steroid for whatever the cause may be, it's going to make their blood sugar go high because it makes them insulin resistant. So the naturally produced insulin doesn't work, so the glucose in the body goes high. Okay, so then all these things kind of start to tie in together. Okay, just kind of in a big circling drain, and it can make the body go into DKA. Okay, so it could be potentiating right there to where blood sugar is high, but not really causing any kind of acidotic state, no excess ketones being going on, maybe just straightforward hyperglycemia. But then when all the cortisol levels are spiking, that sepsis is going in, the body can't fight off infections, cortisol levels pumping, insulin is just kind of becoming ineffective. So no good on the insulin level for us. So we know that the patient was in DKA given by those Kussmaul respirations that were present. So there's those deep, rapid, fast breathing that we could kind of see present here with that increased respiratory rate, and then it's blowing off a lot of that CO2. So crazy low end tidal, but that's kind of that VQ mismatch too, where they're breathing so fast, it's going to be inaccurate. So an ABG is not going to match up to that. Okay, then also tying into this too, hypoperfusion is going to skew that even worse too. So those extreme DKA patients breathing fast, in that acidotic state, hypoperfusing, that end tidal is going to be low. Okay, so if you even really look at this, that kind of is symbolic of that, just by seeing that large peak. All right, so DKA is that metabolic acidosis from our diabetic ketoacidosis. Okay, so it is a metabolic issue because that is the whole metabolic process that is dealing with diabetes as it is. So what the body tries to do is, for that pH scale, it's just very much like a teeter-totter. Okay, so if on the metabolic side, if we've become very acidotic, we've got, two buffer systems, the renal system, metabolic side, and our pulmonary system. So if we're in metabolic acidosis, we go into this respiratory alkalosis, breathing fast, trying to buffer out to keep that pH happy, to keep everything as harmonious as possible in the body. So maintaining that homeostasis. So metabolic acidosis, breathe fast to try to mitigate the acidosis with alkalosis. Okay, so that's where we're going to see it. But this is a buffer system. It doesn't last long. So by the time a patient can get into the Kussmaul respirations, they're already dwindling down. So our big fear is, well, we can't let them sustain this breathing 40 some times a minute for very long, because all the muscles and body that are interacting and causing that are going to wear out really fast. So they're going to go into respiratory failure once they become significantly fatigued. So we got to really start being cautious about the airway of our diabetic and our shock patients. All right, so what are we going to do for management? I mean, it's airway, breathing, circulation, big things. Begin ventilating that patient with that significantly decreased mental status, that they are in respiratory failure when I get to these points. Okay, so right there into that not immediate need for intubation, but that failure is going to come in. That those Kussmaul respirations are not going to last for long, so we need to ventilate them, and then if that is not quickly improving them, but go straight into intubating them. Okay, so as much as cliche as that is of that GCS less than 8 intubate is kind of an old mantra, so we need to get into the understanding of that they are in respiratory failure, And that's why we need to get in and get aggressive with their airway. Their mentation is so bad that they can't maintain their own airway. Physiologically, all of their muscles are so fatigued that they can't support their own airway. So we have to take it over for them. We'll intubate them, protect that airway to prevent any type of aspiration, because in that, the diaphragm is down, the mentation is down, nothing's going to work. So chances of aspiration increase drastically. So protect that airway. Number one reason to be intubating, protect that airway. All right, so things we need to think about is, before they were breathing 44 times a minute and that end tidal was 20. So when we get them tubed, that's kind of where the body was at that was buffering them, if we were fortunate enough to find them in that spot. So what we're kind of looking at here is we're basically doubling the minute ventilation. Okay, so for those patients in acidotic states that we've had to take over their airway and we're getting very aggressive in that airway therapy, we need to double that minute ventilation in those acidotic states. So kind of getting back to where they were before. So we're not trying to worry about keeping this in the harmonious 35 to 45 realm. We're keeping them to double their minute ventilation, breathe fast, same type of volume. Don't change the volume. Don't squeeze the entire bag. It's the same amount of tidal volume. We're just basically doubling the respiratory rate to equal out to double the minute ventilations. All right, and then fluid therapy. And this always is controversial. Always brings up good, online topics, whether we're going to, plasma light, normal saline, lactated ringers. But in this, you're going to follow your local protocols, whatever is out there and what is in your, your repertoire, what's ever in your go bag that you can be implementing. Okay, so a lot of these studies, putting out between normal saline, plasma light, whatever, you just follow your local protocols, what you need to give them. But aggressive fluid therapy, be filling up the container, because if they are in that DKA and that frequent polyuria and with the sepsis, they are going to be extremely volume depleted. So the mucous membranes are giving that away. The hypotension is giving that away. The hypoperfusion state of the capnography is giving that away. The polyuria, all your little detective skills you did, just blatantly give that away. Replace your fluid, give it back to them, and just overall, be aggressive with that airway and just be overall aggressive with your treatment. And always follow your local protocols. So thanks everybody for tuning in to wrapping up this case study. I'm Ben. See you on the next one.